Hi everyone. Thank you for joining us for DrCare's webinar on understanding billing code basics and tips for optimizing practice efficiency. This is always a topic of interest and we are happy to provide information to help address it. A little bit about DrCare. I'll start by introducing myself. I'm Maral Sanassian, the Director of Client Success at DrCare. We are the largest provider of billing and practice support for over 2,500 physicians across Canada. On average, we've helped doctors recover $25,000 to $30,000 of revenue per year. Our solutions and services are designed to help doctors ensure that they are maximizing their revenue, improving patient care, and growing their practice. Our goals for today are the following. We will cover billing code basics on a broad basis to appeal to doctors in all patient enrollment models, including FOs, FIGs, and fee-for-service doctors. In the first part, we'll review the various income streams, and in the second part, we'll highlight a few premiums or often missed billing codes. And lastly, in the third part, we will be sharing the latest updates related to COVID-19 assessments and treatment. Moving into our various income streams. The first part, I thought we'd start with a refresher on the various income streams, particularly for the physicians who are either new to practice and still exploring their options. We also get a lot of questions from doctors who aren't always clear about the different payment streams that are available to them in the model that they're practicing in. So for the purposes of this presentation, things are classified as FOs for family health organizations. So in this chart, you'll notice the different models in primary care at the top. Fee-for-service only and the patient enrollment models, or PEMs, CCM, FIG, and FO. And you will see the different income streams on the left-hand side. We're going to start with capitation. There are two types of capitation, one being the base rate and the other being comprehensive care. First, the base rate. This is the main source of income for a FO. A FO physician gives up most of their fee-for-service to rostered patients in exchange for this capitation called base rate. Now with the comprehensive care payment, every PEM aside from fee-for-service has this payment, and I will explain it in a little bit more detail later. This is a huge incentive to getting into a patient enrollment model because you get paid a monthly amount for each patient on your roster based on the age and the sex, regardless of the visit frequency. To be clear, if you're a FIG doctor who moved to a FO, this payment stays exactly the same, and you would continue getting it in the FO as well. Now the next income stream is the blended fee-for-service. This is an extra fee-for-service payment that you will get when you are in a FIG or a FO. In a FIG, it's a 10% premium to certain bills. In a FO, it's 15% shadow billing, and it's the value received for in-basket billings to rostered patients. Moving on to special premiums and bonuses. These are the annual payments that you will become eligible for in each model depending on the specific billing thresholds. We'll go into them in a little bit more detail later. Out of baskets, another income stream. These are billing codes that are paid out in full value. These end up being a big part of billing for a FO, since these are codes that are paid out in full value even though physicians are earning the full capitation on these patients. Next is the classic fee-for-service income stream. All models include fee-for-service. Now, with a FO, there is a restriction where a group hard cap of about $56,000 per physician is set on in-basket services provided to non-rostered patients. Anytime a group goes over this cumulative hard cap, which is rare in my experience, the group will be asked to pay the overage back in full to the ministry. It's important to know that if you do a lot of billings to non-rostered patients, like methadone or pain, the FO model is usually not the best model for you. Please keep in mind that the hard cap has currently been raised to $1 million during the pandemic to ensure physicians do not go over their hard cap in the 2020-2021 fiscal year. Preventive care bonuses. So we're going to go into this in more detail a little bit later, but there is a maximum for this income stream set at $12,800 available every year to any member of a patient enrollment model. And when it comes to access bonus is actually only available in the FO model and it's approximately 20% of your base rate capitation payment that is held back and can be earned by physicians when their enrolled patients do not seek care for services listed in the contract outside the group with which the patients are enrolled to. And last but not least, the after hours, which is included in the CCM, FIG, and FO models. It is a premium received for doctors performing services outside of their regular hours. So moving on to capitation. There are two types of capitation lumped up. You can see on this slide that the total capitation is made up of the base rate capitation and comprehensive care capitation. Both are calculated by age, sex, and the number of days the patient is on your roster. The average base rate for a patient is $202 per patient per year, while the comprehensive care is about $40 per patient per year. Moving on to preventive care bonuses. So we're going to dive a little bit deeper into this. And this bonus has actually been in existence since 2008. So as you can see on the screen, each bonus category corresponds to a different age group. We always recommend using the Cancer Care Ontario Screening Activity Report to track your patients as they go through the health system to keep up to date on patient compliance and for you to achieve the best results. The fiscal year ends on March 31st every year, and you have 6 months to reconcile for this bonus. So for your 2020-2021 bonus, these are due on September 18th at the latest. Please don't forget about the colorectal cancer screening fee, the Q150, which is worth $7. It can be billed on enrolled and non-enrolled patients. Special premiums and bonus income streams vary a lot depending on the different patient enrollment model as illustrated in this chart. So as you can see, the full model contains all the special premiums and bonuses available, whereas the CCM model contains only about half. So like the preventive care bonus, this is also dependent on the ministry's fiscal year ending on March 31st. This slide illustrates the premiums available for attaining the different thresholds. I want to spend some time on the primary care serious mental illness category specifically because we get a lot of questions on it. As a doctor in a FIG and a FO, if you have any rostered patient who has bipolar or schizophrenia, you should be billing the corresponding tracking code of either Q020 for bipolar or Q021 for schizophrenia, and you can add this to their visit. Once you track a total of 5 patients for the fiscal year, you'll get paid $1,000, and once you track a total of 10 patients, you will attain an additional $1,000 for a total $2,000 bonus in this category. Moving into part 2 of our webinar. This portion is on premium billing codes and often missed codes. The following set of codes should be maximized by doctors in any patient enrollment model. First off, I want to start with the Q codes, the most popular and most billed ones. Most of these are pretty straightforward. So the Q200 is for rostering. You would be using this frequently. The Q202 is specifically for long-term care rostering. After hours wise, there is a special Q code where it's Q012 that you would bill with the service that you provide, and this would be eligible for any after hours time after 5 p.m. on a weekday or any time on a weekend. In a FIG and a FO, it's the Q012, however in the CCM, it's the Q016. Moving on, the heart failure management incentive is eligible for all of the different patient enrollment models. The Q050 is billed when you complete the flow sheet, and I'll go into more detail later. As mentioned in the previous slides, Q020 and Q021 are tracking codes that are billed for patients that have been diagnosed with bipolar or schizophrenia. We've got the Q042, that's a special code that you would bill for patients that you do smoking cessation follow-up on. So along with that service you provide, you would typically bill the K039, and you could add this Q code, the Q042, and you would get a top up to the K039. This is eligible for anyone in the patient enrollment models, so CCM, FIG, and FO. And last but not least, we've got the Q015. This is an add-on code that you would bill with the A007 service code that you would provide on any patient under the age of 1. And it is eligible for 8 times within the first year of the patient's life. You get $14 for this, so there really is a big incentive there. I'm going to dive deeper into some specific out-of-basket codes that we want to spotlight. The first billing code that we're going to focus on is diabetes. because there are tons of opportunity here and it's relevant to all doctors irrespective of their patient enrollment model. Diabetes is broken up into two different codes. So I'm going to focus on the first one, which is Diabetes Management Assessment, the K030. This K030 is equivalent to the A007 that you would typically bill for seeing the patient. This code can only be billed 4 times per year per patient. And regardless of their roster status, it could be on an enrolled patient or a non-enrolled patient. Now, the most important part is the requirements involved with the K030. You have to complete what is defined by the ministry as a diabetes flow sheet. The flow sheet is very straightforward and asks you to review labs, so the A1C lipids and cholesterol, reviewing the blood pressure, weight, and BMI, do a medication review. We've also listed out the other items that you have to cover, like preventative measures, documenting health promotion, counseling, and also talking about doing a foot exam, neurological examination, and then coordinating the dilated eye examination that you would do for a diabetic. This code bills at $40.55, and just by doing these things that you would typically be doing for a diabetic patient, you would get a lot more money than a typical A007 visit. So the second part of diabetes management is the Diabetes Management Incentive, the Q040, which pays you at $60. This is only eligible once a year per patient, regardless of their enrollment status, and there has to be a minimum of 3 K030s done alongside completing the flow sheet each year. This is an important rule and why it is important to bill the K030 instead of the A007. It's what allows you to become eligible for this diabetes management incentive. In response to COVID-19, the Ministry of Health introduced a new virtual care code, the K081, that can be billed for diabetic visits. This code is eligible to contribute towards your Q040 Diabetes Management Incentive Code. We will go into more detail about this code later in the webinar. Just to close out diabetes, there is actually one more out-of-basket code for a specific type of diabetic patient. It's called the Insulin Therapy Support K029 code, and it pays out at $67.75. And there are some requirements with this code. The number one and the most important thing is that these patients that you're going to be billing the service for have to have at least 3 or more injections of insulin per day that they're on and or are using the insulin pump. So it's not for all diabetics. And the service that is provided by you as a physician has to be at least a minimum of 20 patients with the patients during the visit. So it actually is a time-based code like your typical counseling code. One more important thing as well is that there is a maximum that you can bill this code. You can bill it for 6 units per patient per physician per year. And from our experience, you don't typically see many of these patients, so you don't typically max out on it, but it is good to be mindful of the limitations. It is a big opportunity to bill this code for that target population. And we would recommend that you would bill this code instead of the K030 if it is a better fit for the patient that you're seeing and the care that you're providing. Another out-of-basket code that we want to spotlight is the smoking cessation. There's huge value here as it brings good patient care, and there's good value that you can get from these billing codes in terms of revenue. The first one is the E079 for the initial discussion with the patient. It pays $15.55, and it is an add-on code with a service. The most important thing in terms of requirement is that you must document the discussion in the patient's medical record using some sort of flow sheet. So there are a bunch of different recommended flow sheets from the ministry, and these flow sheets just have to align with the requirements. The thing that you have to understand for the payment rule side of things is that the E079 is only eligible for payment when rendered with one of the specific set of services that we've set here. It has to be billed with an A007, for instance, or an A003, or even the prenatal codes, P003, P004. If it is not billed with one of these codes, it actually gets rejected. And so that is why it is important to know the code that you're going to bill with the E079. And last point about the E079 is that there is a maximum that you can bill. It's one service per patient regardless of their enrollment status over a 12-month period. So here's an example of that flow sheet that we just spoke about that we recommend that our clients use for doctors that work with us. There's a bunch of them that people can use and that are simple and they are effective. The flow sheet helps because it aligns with best practices. Moving on, there's a couple of other codes for smoking cessation. So the other two are the K039, the smoking cessation follow-up visit, and the Q042, the smoking cessation counseling fee add-on. The K039 is paid at $33.45. This code is billed after the initial discussion happens, which is the E079. The focus of this one here is to continue the dialogue about smoking cessation with the patient. You can try to address the concerns and the reasons for not quitting smoking during the visit. And so what we recommend is that there is also a flow sheet available for this K039 that aligns with best practices and that can help facilitate the conversation. It is important that you document the visit, and a couple of pointers are that there's no specific time requirement for the K039. So it's one of those K codes that actually doesn't need to be defined by that minimum 20-minute time span. You just need to make sure you document what you discuss, and it does have to pertain to smoking cessation. And again, you can use the flow sheets that are out there, like the one that we just demonstrated, to facilitate the conversation. In terms of payment rules, as mentioned before, it does have to happen after the E079. So we need to have an E079 paid prior to the K039 being paid in the last 12 months. And the K039 is limited to a maximum of 2 services in the 12 months following that initial E079. So now let's move into the add-on code, which is the Q042, paid at $7.50. You would typically add this onto the K039 code that you're billing, and it's an additional incentive payment for physicians to provide that counseling sessions to patients that are rostered. So here, if you bill this code on a non-rostered patient, it won't get paid. But it should help you focus on your rostered patients and give this kind of counseling to them. A couple of things here, similar to the K039, is that the E079 has to be billed previous to this Q042, and the Q042 is billed in the 12-month period following that E079. It is limited to 2 in the 12 months following that E079 and only applicable again to rostered patients. So as mentioned before, there's a flow sheet that can help facilitate the conversation for the K039 billing. And so this is the one that we would recommend because it aligns with best practices. It covers a wide range of different areas for that conversation. It's very comprehensive, and the feedback we typically get from doctors is that it's very helpful for them to have that conversation with their patient. So the next out-of-basket set of codes that we want to discuss is the prenatal and postnatal care codes. We're going to talk about the rules and the requirements, as we did before, and also some best practices for billing. The first code to spotlight for prenatal is the major prenatal visit, which is a P003. This code pays at $77.20. I like to think of this as an A003, very similar to that general assessment, and yet on a pregnant patient. Now, the maximum you can do for a P003 is 1 per patient per physician in the last 12 months. And an important thing to note, and why we have the asterisks here, is that pregnancies are typically 9 months, so there might be situations where you bill the P003 again in the 12 months. In our experience, that usually isn't a problem, but there is a rule of thumb from the ministry that you only use it once every 12 months on a patient. So now this is typically completed on the first visit once pregnancy has been confirmed. And from our experience, most doctors like to complete in that first visit just to make sure all the labs and all the items are covered in that discussion. In terms of best practice, we recommend that you follow the 2017 Ontario Perinatal Form, formerly called the Antenatal Record 1. We would follow that because it is very comprehensive in terms of what needs to be covered in that first prenatal visit, the major visit. And from there, it's typically about 30 to 40 minutes because it is a bigger visit. There's a lot of things to cover regarding the pregnancy. If you do need a copy of that perinatal form, the 2017 one, please feel free to contact us and we will happily send it to you. So after the major visit, physicians would be billing the minor prenatal visit, the P004. This one bill pays at $36.85, so very similar to an A007. It's basically the code that you will bill for all the other prenatal visits that you would have with the patient going forward. You would include the typical stuff that you would cover, which is the history exam, doing any examinations that are appropriate, recording what you're doing, advice to the patient. There's some counseling component there, which is typically billed for in subsequent visits until patients are referred or accepted to the OB. That's a couple of weeks out. It's different for every physician based on their relationship with the OB or the patient's requirement, but it's the 22 to 28 weeks that you would see these patients for that you would be billing the P004 typically until. Best practices, again, using that 2017 Ontario perinatal form. And for the P004, we do recommend using the record 2 and 3 and updating those. As well, there's some great resource documents in that perinatal form that we always recommend. It has a lot of good resources there that physicians would find useful. When a pregnant patient visits her physician for a condition unrelated to the pregnancy, and this is a big thing that we get asked quite often, and it's apart from her routine scheduled prenatal visit, the physician may claim the appropriate assessment fee. The way that I like to look at it is that if that visit you had to address the pregnancy or there was something related to the pregnancy and you had to do an assessment or examination, it's appropriate for you to be billing P004 at the time. So again, reinforcing the point that if the visit has to do with something related to the pregnancy, you'd be billing the P004, the minor prenatal visit. So the third code for the prenatal side of things is the P005, and it's the Antenatal Preventative Health Assessment, which pays out at $45.15. There's a specific client requirement for this code, and it's to conduct an initial review of the antenatal risk. You would examine specifically the current psychosocial, genetic, and medical issues affecting the antenatal risk. And this is part of your typical best practice that you would be doing for patient care for someone during their pregnancy. Here, you would be billing this P005 maximum once per pregnancy. The one thing that we've noticed is that it is typically done during the P003 major prenatal visit when you're completing the record 1, because a lot of the record 1 has those components in there, and from our experience, it's typically done during that visit. The one thing that we would recommend is that you never bill the P005 by itself. You're already probably doing most of the work during your P003 or perhaps your P004 visit. So we recommend you bill it with one of the others, as it only takes a couple of additional minutes, about 5 to 10 minutes to cover this part. So you could do it along with one of those visits. Last one of the set here is the Postnatal Assessment, the P008. This one is billed at $36.85. So for the mother, this is the first time you see your physician post-childbirth. When the mom comes in with a newborn, it is recommended that you schedule a time to see the mom as well as do the postnatal assessment then. Here you would bill a P008, and the maximum you can bill this code is unlimited within the first 6 weeks after delivery. In terms of best practice, there is a form available in the perinatal form, page 5 of the postnatal visit, that gives you a framework of what to cover during that postnatal visit. A lot of doctors have found that very useful. And I just want to reinforce that the point here is that you should be scheduling this visit when the newborn visits are happening so that you can see the newborn and then see the mom right after in terms of best practice. So with regards to the ministry forms, this is a big thing that we often hear, so we thought we might as well cover one specific type of form that you can bill for, which is the Ontario Disability Support Program, the ODSP. As of May 1st, 2017, the Administrative Community and Social Services simplified this. So before that, it was a variety of different codes, and it was always confusing for physicians to figure out which one they were supposed to bill or which of the forms they were supposed to fill out. Now there is a new type of form since May 2017, and there are new sets of billing codes. So the way that they have streamlined this is that they've made it into two parts. So there's a medical form part A, which is the mandatory part, and it asks your patient's previously identified medical conditions, impairments, and restrictions. Pretty straightforward. Part B, in and of itself, is really about the health status report and activities for daily living index. These sections are what make up Part B, and typically it's optional when you're filling out the ODSP forms, unless it's requested by the patient. So they've really streamlined these two components of the form. And so what the ministry has done, prior to May 2017, there was a lot of variety to the different codes there, as you can see on the screen, and it was very confusing to identify which ones to bill. And now they've streamlined it to only a couple of codes that you would be billing specific to the parts of the form that you're filling out, either Part A or Part B. We've made it clear here because no one likes the schedule of benefits version, so here are the 4 types of codes that you can bill. If it's Part A you're completing, you would be able to bill the K057, and in Part B, it's based off if you're doing one of the other sections or if you're doing both of these sections. It's very clear now going forward, but if you have any questions, you can always feel free to contact us if you need us to send you the forms or need any other guidance from our end. So now moving into our final part of the webinar, Part 3, COVID-19 OHIP billing codes. Over the past year, the ministry has made numerous updates and changes to OHIP billing codes to address the challenges related to the COVID-19 pandemic. We have seen that the volume and frequency of changes has been hard on physicians trying to keep up and manage their billings and their practices. So we will go through the various updates of the billing codes in the following couple of slides. On March 14th, 2020, the ministry and the OMA created 4 temporary OHIP billing codes in the schedule of benefits to facilitate telemedicine and virtual care. While these fee codes are not limited to COVID-19 screening or COVID-19 patients, they have been put into place in an effort to reduce the risk of disease spread by keeping people at home and out of doctors' offices. On April 4, 2021, the ministry announced an extension on the 4 primary virtual care codes until September 30th, 2021, and introduced a new set of virtual fee codes for palliative care. The first virtual care code is the minor assessment, the K080, which is $23.75. It is the minor assessment of a patient by telephone or video, or advice or information by telephone or video to a patient's representative regarding health maintenance, diagnosis, treatment, prognosis. The second code, the K081, which we mentioned earlier, is the virtual code for the diabetic management incentive, pays out at $36.85. This code includes the intermediate assessment of a patient by telephone or video, advice or information by telephone or video to a patient's representative regarding health maintenance, diagnosis, treatment, prognosis, if the service lasts for a minimum of 10 minutes. This code also includes the service for the psychotherapy, psychiatric or primary mental health care, counseling, or interview conducted by telephone or video if the service lasts a minimum of 10 minutes. We know this must be tough to track through your EMR, so we have developed a report that identifies all K081s that were billed against diabetic patients and which Q040s are eligible as a result, your diabetic management incentive. If you need assistance for this, simply contact us and we'd be more than happy to help you with that. The third code is the primary mental care, counseling, or interview code, which is the K082. And this one pays out at $23.75. The service includes psychotherapy, psychiatric or primary mental health care, counseling, or interview conducted by telephone or video per unit. And again, a unit means a half hour or major part thereof. The fourth code is the specialist consultation, K083, paid out at $5. This code is for a specialist consultation or visit by telephone or video payable in increments of $5. The K083 essentially allows you to bill all your usual fee code amounts for telephone or video assessments. So moving on to palliative care virtual codes. the Ministry of Health announced 4 new codes to help support physicians providing palliative care services to patients during the pandemic. The 4 codes are the K092, K093, K094, and K095. The K092 and K093 are considered special palliative care consultations, while the K094 and K095 are considered palliative care support fee codes. K092 and K093 are requested when the need for specialized management for palliative care requires the physician spend a minimum of 50 minutes with the patient and/or the patient's representative or family in consultation by video or telephone. The majority of the time must be spent in consultation with the patient. In addition to the general requirements for a consultation, the K092 and K093 fee codes include a psychosocial assessment, comprehensive review of pharmacotherapy, appropriate counseling, and consideration of appropriate community services where indicated. The K094 and K095 are time-based services payable for providing pain and symptom management, emotional support, and counseling to patients receiving palliative care by video or by telephone. These are payable in increments of half an hour or the major part thereof. The next update is the new diagnosis code, the 080, with the description coronavirus. This diagnostic code has been created to be used when the primary purpose for the service treating a patient with a suspected or confirmed case of COVID-19, whether in person, by telephone, or video. This code can be used for all inpatients with COVID-19 as well as any emergency patients. Next up is COVID-19 vaccine codes. So on March 6, 2021, the ministry announced new fee codes to support the vaccine rollout. There are 3 specific codes that you can bill for administering the COVID-19 vaccine: the G593, Q593, and the Q007. The G593 is the code you use to bill for the administration of the COVID-19 vaccine for each patient. The Q583 is eligible for payment with the G593 when delivery of COVID-19 vaccination is the sole reason for the patient's visit. And for the Q007, it is billed for the COVID-19 vaccine patient facilitation and can only be billed once per patient. So note, you cannot bill these codes if you're working in a COVID assessment center. You will bill codes H409 and H410 instead, which we will be getting into in the next section. So the 2 sessional OHIP fee codes, H409 and H410, are billed for physicians supporting vaccination services at hospitals or public health units, coordinated by COVID-19 assessment centers. All services rendered on or after December 14th, 2020 at the hospital or public health unit coordinated COVID-19 vaccination sites are eligible for payment with the H409 and H410 fee codes. The H409 are for services on Monday to Friday from 7 a.m. to 5 p.m. and the H410 code is billed for services on Saturdays, Sundays, holidays, or Mondays to Fridays from 5 p.m. to 7 a.m. The 2 sessional fee codes must be billed for every hour of service provided. So for example, if you work supporting vaccination services on a Monday for 2 hours during office hours and 2 hours after 5 p.m., you will bill as follows. You'll bill the fee code the H409 for 2 units for $340, and you would bill the fee code H410 for 2 units at $440. So those are the key billing codes that have been updated in the past year in response to the COVID-19 pandemic. And if you would like more details on the changes to the OHIP billing codes, visit the blog on our website, A Comprehensive Guide to OHIP Billing Codes for Virtual Care and COVID-19. That is the end of our webinar. On behalf of DrCare, thank you so much for joining us today for this webinar. If you have any questions, have any feedback on this webinar, please feel welcome to contact me at any time. My contact information is listed on this slide, and I hope you have yourselves a wonderful day.